Cataract session is starting. Uh, I welcome you all, the panelists and the guest speakers. Today we have 8 speakers and uh, hope we have a wonderful session now. I'm very happy to welcome the first speaker. We have Dr. Rajendra Prasad from Delhi. He will be talking on a terminal chop, an easy way to manage difficult hard cataract. He's an alumni of AIMS, a very famous institute in India, and he is presently a director and senior consultant at RP Center in New Delhi. He's a very innovative surgeon. He has a lot of innovations under his belt, and his terminal chop technique is very famous. He has also invented many different modalities like terminator of wedge tool, hydrodissect of PCC, sewing needle microcapsulotomy, and T-soft technique for a soft cataracts. He's a great speaker, and he has presented numerous presentations in multiple conferences all over the world. So I'm glad to welcome Dr. Rajendra Prasad, and over to you, sir.
Okay, can you see my screen?
Yes. 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 Yeah.
Hello, everyone. Good evening. And first of all, I'd like to thank MIOC for inviting me for this webinar. And I'm really happy to be with all of you here in this beautiful evening. The subject which I'm going to talk about is the terminal chop, an easy way to manage the difficult hard cataract. Friends, we know that these hard cataracts have always been a challenge to all of us, and they present series of specific and difficult challenges during the surgery. Apart from the initial challenges which is involved with the capsular axis, separation of the nucleus from the capsular bag, rotation of the nucleus, making it free. So one of the biggest challenge which we come across with these hard cataract is they don't break easily. So this is the biggest problem. And it becomes very difficult to achieve full thickness nucleus segmentation. And you all know that unless we get the complete segmentation of the nucleus, emulsification and to accomplish the successful result is very difficult if you don't have the complete segmentation of the nucleus. There are several techniques which we all have been practicing now for the last 3 decades. And practically, we all know that quite often we come across the problem of segmentation of these hard and rock hard nucleus. And that start giving us the problem during the surgery if we are not able to segment. And many times we have to opt for these hybrid technique where you have to do divide and conquer and other techniques like drilling and then making a crater and all. And we know all these techniques need very high energy levels. We need to use very long phaco times, stressful long manipulation, and most of the time we use compressive crushing mechanical forces to crush the nucleus and then try to emulsify. These factors not only increases the risk of endothelial damage, but also increases the risk of thermal injury, which we many times come across in these hard cataract. Also mechanical injury in the form of iris trauma, PCR, or jonular dialysis. All these complications we have been coming across with these hard cataract emulsification. So I'm here to tell you about one of the very simplest, very safe, and very efficient surgical technique, that is terminal chop for the hard cataract management. And this is what I feel is the very easiest way to break these hard nuclei into free segments. So once you get the free segments, then it becomes very easy to draw these free segments on the phacoprobe, and then you can emulsify them very easily with very less stress and less energy levels. Now, what is terminal chop? Terminal chop, actually, it works on the principle of brittle crack propagation with tensile fracture force. So this was described by the Griffith somewhere in 1920. And this phenomena actually works for the rock excavation system. So where the people used to break these hard rocks in their uh, mining and other field. And we know that these, according to this theory, these any solid hard objects, they are highly resistant to shearing or compressive forces. Shearing means like chopping, trenching, crushing, drilling, and cratering. So all these forces, they are shearing and the compressive forces. That is what we also have been using to break our nuclei throughout these 3 decades to break the nucleus with our horizontal chop or vertical chop. We use these forces, but we know that these forces are very, you need a very high energy level, you need too much of forces to break these hard objects. But one very important character of these hard object is they have a very low tensile strength. That means they crack very easily. But if you like to, if you go for crushing them, if you go for cutting them, it will be very difficult, but you can crack them very easily. And the cracking is done with the tensile fracture force. So they crack with the tensile
Why?
fracture force very
Wedges have
easily.
been fixed in system since the ancient time.
Now this is
Cracking
what
force is generated by
these
chisel rattle,
objects have
a
been
specially designed wedge tool.
used
It has been
by the
applied at the open edge
uh,
of these
the
hard
rock
rocks
excavation
with a
system, because they use this technique to break the hard rocks. They use a special device to crack these hard rocks, and this is used to open up the hard object from its open end. So if you have an open end of that object, you can open it up from the open end, and then this crack automatically propagate through the center and to the whole entire that hard object, and it breaks into two complete. That is what we have seen in rock excavation system. And terminal chop uses the same technique. So what we do in terminal chop is like we create a crack at the equator of the nucleus. We create a crack at the equator of the nucleus. Now this is called as the crack formation. And most of the time, the crack which is created at the equator automatically traverses throughout the entire nucleus. So you get a complete segmentation of the nucleus. But sometimes you have to use crack propagation. That is, you have to split the nucleus, because you create a crack and then you split the nucleus, like what it is being shown here in this second picture. You are splitting with the help of the cracker as well as the phacoprobe, and then you segment the nucleus into two complete segments. So these are some of the videos I'll show you. And the important point, what you can see here is, now this is, the beauty of this technique is it can be used for any grade of the nucleus, not only the hard or rock hard cataract. What I'm showing here is the grade 2 nucleus. So you can see how simply you can crack the nucleus. So you crack the nucleus into two complete segments with the help of a very simple mechanics. You just hold the nucleus just within the equator, hook the device around, and crack the nucleus. So you can see here the crack, which is initiated at the equator, simply propagate through the entire nucleus, and you get a complete entire segmentation of the nucleus. Now this is the grade 4 nucleus, little harder, and you can see how simply you can crack these hard nuclei into two complete pieces. And this actually gives you a very successful result, because since you are breaking the nucleus into free segments, so then it becomes very easy to draw these pieces on the phacoprobe, and the emulsifications become very easy. Now this is grade 4 nucleus again. See how simply you can crack these hard nuclei into two complete segments. Now this is the grade 5 nucleus, dark brown nucleus, but still you can see here how simply you can crack this nucleus also into two complete segments. This is how you hold the nucleus, hook the device around the equator, and then crack and split. So that is what I said, like sometimes you have to use the splitting force. So this is how the splitting takes place, and this split goes throughout the nucleus, full thickness. So in most of the cases, like you will get a complete full thickness segmentation, even you will never get the posterior plate will be left. Even the posterior plate is also cracked, because since you are hooking the device all around the equator of the nucleus, so you get a complete segmentation of the nucleus. You are not left with even the posterior plate is also broken. Now this is grade 6 nucleus, how simply you can crack. Now you can see this is the Cataract nigra, grade 6 and NS6 nucleus. How simply this kind of nucleus can also be broken so simply with this device and the technique. So this is how you break the nucleus. So once you break the nucleus completely, then you can rotate the nucleus and rotate the nucleus and create multiple pieces so that you have multiple free segments for the emulsification. It depends on the hardness of the nucleus. So you can make 4 or 6 pieces. The most important point in this technique is the device. The device what I'm using here is the terminator, the wedge tool. Now this is a device which is actually developed and designed with the principle of classical simple machine, the wedge. We all know that there are 6 classical simple machine. One of them is the wedge, and these wedges are actually triangular prismatic kind of structure you can see here, and which has a 2 inclined plane which meets at the tip, pointed tip, and it has a base, broader base. And when this wedge is actually forced, entered into a hard object, it splits the object into 2. So this is how you can see here, how it splits the object into 2. The principle behind the wedge tool is like it gives you a force redirection, like the radial force which is used from the base of this wedge is converted into the transversal fracture force. So this is how it fractures or the separate an object into 2. So this is the way, and it depends on the angle of the wedge, and the force amplification and the force redirection will depend on the angle of the wedge. And what we have found was like the 75-degree angle of the wedge gives you the maximum force redirection and the maximum force amplification.
A flat profile tip
so
with
you can see here, this is
either with sharp
the
or
device
blunt
which
inner
we
edge,
normally use
designed
for
either
our
to
chopping
facilitate
techniques. And so what we have done actually is
used in rock
this
excavation system.
a
The
triangular
tip is
wedge
incorporated
device
with
was
triangular
incorporated
used in rock
into the
excavation
tip
system.
of the
The tip is incorporated with triangular wedge design. Apex at the inner edge of the tip, while wide and flat base at the posterior surface of the tip. Tips with several vertex angle of the wedge inner edge were tried. We found that the tip with 75-degree angled wedge generate maximum transversal fracture force with highest amount of force amplification.
So you can see this is the 75-degree angled wedge with the olive tip. So this is very important because since this has to be hooked around, so we have made the tip olive and round tip. And to fracture the nucleus, so there are 3 important points which needs to be seen here. Your phaco probe has to impale the nucleus from the center towards the equator. So you can see here, the phaco probe has to impale from the center towards the equator. It enters from the center, and it has to go superficially within the nucleus. You don't have to go deep towards the posterior capsule as we do in the vertical chop or horizontal chop. Here it is superficial. You have to draw the nucleus a bit, hook it around, and then crack it. So this is how you crack the nucleus into 2 complete segments. So positioning of the phaco probe is very important. This is what the phaco probe has to be positioned just within the equator, superficially within the nucleus, and the device has to be hooked around. So the hooking has to be complete. This is how you have to hook the device, and this is the position. And now once you have hooked it, the nucleus has to be slightly drawn. So when you draw the nucleus, then you see the edge of the nucleus, then only you can hook it safely under visualization. This is how you hook the nucleus, the equator of the nucleus, under visualization. And what you have seen here is, you can see this figure here. The nucleus, when you're drawing the nucleus makes a slight vertical tip. So it doesn't produce any stress on the granules because while drawing the nucleus, because it makes a slight tilt. And then the fracture force is given by the wedge tool, and the counter force is given by the phaco probe. So this is how the counter force is given, and you fracture the nucleus here, and then you need to split it. So you can just see this animation video here, and this is how the phaco probe has to go within the nucleus towards the equator. It has to hold the nucleus here, and once it has held the nucleus has to be slightly drawn. So you can see the nucleus slightly drawn within the capsular edge, and then it has to be hooked full thickness. The hooking is very important. Then you create a crack, and this crack automatically traverses through the nucleus, through the entire nucleus, and it breaks the nucleus into 2 complete segments, and then into 4 or 6 pieces as the density of the nucleus is there. This is how you break the nucleus into the 4 different pieces and then start the emulsification. The frequently asked question, like what should be the phaco settings? Phaco settings are the standard phaco settings, like you keep the energy around 30 to 40. We normally use white pulse mode, and vacuum should be around 400 to 500, flow around 25 to 30. The important point is the phaco tip should be 0 degree or 15 degree, not more than that, because the holding of the nucleus at the equator, your phaco tip angle should be low. That is one thing. And the second question which is asked, as I already explained, like drawing the nucleus, does the drawing the nucleus produce any stress on the generals? No, not at all. You can see here in these figures, I'm holding the nucleus here, drawing the nucleus makes a slight tilt. You can see the tilt. So when it makes the tilt, it is not hitting the posterior capsule anyway. So it will not produce any stress on the zonules. Hooking is very safe because the tip of the device is made round and olive tip. So even if it touches the posterior capsule, it will not threaten the posterior capsule at all. And how it is different from the horizontal chop. You can see in horizontal chop, your phaco probe is going deep into the center. Here the phaco probe is superficial. And the hooking is not done in the horizontal chop. You're just keeping the chopper at the periphery and under the capsular bag, the capsulotomy edge. Here you're drawing the nucleus and hooking it all around. And the cracking is done at the equator. Here the cracking is not done. You just cut the nucleus toward the center and then you try to split the nucleus at the center. But here the cracking is done at the equator and you split the nucleus from the equator itself and you get a complete segmentation. So to conclude, terminal chop are very simple, very safe and swift, easy to perform. Minimal phaco energy is required, shorter phaco time is required, least traumatic, and minimal manipulation, and you get a very effective result and a beautiful result. Like you will get a crystal clear cornea on the first day itself. Thank you very much.
Thank you so much, doctor. It is a wonderful technique. We should practice it. I mean, it will work probably with the best hand initially, but wonderful technique. I mean, you have worked thoroughly on its mechanics, it seems.
Yeah.
So we'll because of lag of time, we'll just quickly move to the our next presentation. I'd like to welcome Dr. Jeevan Ladi. He will be talking on praise myopia management in cataract surgery. Dr. Jeevan Ladi is a very renowned surgeon from.
The video is not starting. My video is just okay. Thank you.
Yeah, Dr. Jeevan Ladi is a very famous, renowned surgeon. We call him a premium surgeon from Western city of Pune. He is a gold medalist from my institute, KM Mumbai, and he has done multiple fellowships in cataract and refractive surgeries from Switzerland, from USA, from Thailand, and he has multiple peer-reviewed publications as well. And he has started doing phaco surgeries a long time back. I mean, probably that time we were just small kids, I would say. And he has 17 ophthalmic publications in various journals. So I'm glad to welcome Dr. Jeevan Ladi and welcome you, sir. I mean, over to you.
Thank you, Dr. Devdatta. At the outset, I would like to thank Muscat Ophthalmic Society, all organizers, all dignitaries of the society, all the faculties, Dr. Devdatta, Surveshi, my friends. So I thank you all for inviting me to talk on presbyopia management in cataract surgery. There is no financial interest in this presentation. So presbyopia correcting IOLs available presently are refractive, diffractive, apodize, acrylate, or extended depth of focus, intermediate, mix and match, that is low add for dominant eye, high add for non-dominant eye. Segmental multifocal IOLs, Crissa lens, which was accommodative, near worked very well. Toric multifocal, pseudophakic circumflex, or refractive multifocal IOL. As far as the choice is concerned, distance is fairly well with all multifocal IOLs, while diffractive gives a very good near vision. For active lifestyle like computer, night driving, extended depth of focus lenses are better. For intermediate, which is falling between the monofocal and multifocal, this lens is good. Any astigmatism of more than one diopter, toric multifocal IOL is used. When asked first question whether they want to get rid of glasses, if they say yes, then the discussion about the multifocal starts. Profession, reading, computer use, driving at night or on highway makes us decide which lens to be choose. And then we ask whether they are willing to get their both eyes on within a period of 3 weeks for better neuro adaptation. If you are planning for monovision, don't cross your target of more than 1.5 diopter of myopia, otherwise patient will get glare and halos and may not be happy. We tell patient there are no 2 zones, there are 5 zones after the age of 40, and all 5 cannot be corrected by any technology. So how the focuses are being placed? If you see that monofocal and EDOF lens has got a single focus, while here it is an elongated focus, while multifocal IOLs will create a 2 distant foci, that is bifocal or trifocal, and that's why the glare is more, while here the glare and halos are less. So how do we make a choice? Extended depth of focus of lens and multifocal. Here it gives a band of focus, while here there are 2 or 3 sharp foci are there. The range is wide, usually used for housemaker or indoor workers, while here we use it for outdoor workers and active workers. Potential acuity has to be good, that is better than 6/9. While here the potential acuity, even if it is less, we can use +4 add, which works as a low vision aid, and patient will be happy. While this is used for more younger patients with active life, night drivers, here you can mix and match between different type of ads, multifocal lenses, less glare and halos, here more and glare and halos. This absorb minor refractive error, while here this needs accurate biometry. Contrast is better, while contrast is slightly poor. This is a one-piece lens, multifocal lens. It is pupil independent diffractive design, and light is divided 50% for distance, 50% for near. Apodize technology is periphery is a refractive design, while 3.5 to 4 millimeter in the center is a diffractive design. This is yellow color lens so that night glare and halo is reduced by reducing the chromatic aberrations. This is extended depth of focus. The technology is called as Cataract design. It has got an elongated focus than a single point focus, gives good distance and intermediate vision, there is less glare and halos. This is achromatic, that means light is not divided like multifocals. This works just like monofocal lenses. To get full range, we can make one eye myopic by 0.5 diopter, so you can have multiple range. If patient is not suitable or willing for a multifocal IOL but wants some intermediate vision, then you can use this, which is a refractive, continuous, higher order aspheric lens, which is a distance dominating lens with little bit of intermediate vision. Segmental lenses are placed 12 to 6 o'clock. Top part is for the distance vision, lower part is for the near vision. This is variation of that is Femtis lens. This has been fixed to the anterior capsule. Now, if you see trifocal lenses, they look just like any multifocal lens. The light is divided again 50% for the distance, 30% for the near, and 20% for the intermediate. So by look-wise, the lens looks just like any multifocal lens. Now, patient comes with one eye pseudophakia, monofocal lens fused, and cataract in other eye. What do? We can put in other eye diffractive multifocal and put a piggyback lens in sulcus for eye having a monofocal lens. This is how the lens looks, 6.5 millimeter optic, refractive design. Now, if you see this patient is pseudophakic, this is not a multifocal lens, this is a monofocal lens with little bit of PCO here. And this is a 6.5 millimeter optic with 3.5 add. So lens is slightly more than what we usually use. So you have to be really careful when you are folding this into the cartridge. This is the only care which you have to take. Otherwise, this lens works beautifully. As you can see, it has got a refractive circles and very pliable haptics. Once it is done, the surgery can be literally finished in 2 to 3 minutes. You can put the lens on the top of this lens, and these haptics are pliable and very compatible and goes into the sulcus. See to it that you remove the viscoelastic from the anterior chamber and in between the lens, and this is how it will look at the end. This patient, we wanted to put toric multifocal lens, but somehow the pupil was small. We thought it may be there because of intermittent cataract, but as we proceeded with the surgery, the pupil were coming down and did not realize what it was till we noticed a subluxation here. So we filled the chamber, put the CTR, and once the CTR was put, then you can proceed usually. This lens has a 4 markers, so even with the small pupil, you can see the markers well. As you can see here, that alignment can be seen quite well. This is patient with keratoconus with cataract, stable keratoconus, cylinder of 7.25 diopters and corneal astigmatism of 1.84 diopters. So we order a customized lens for these patients. It takes around 4 to 6 weeks. The flax is done by femtolaser cataract. The lens is produced by Care Group from India. There is no financial interest. The advantage of this lens is that irrespective of the cylinder, all lenses can be aligned 0 to 180 degrees. So as you can see that even if the cylinder is in a different angle, all lenses are aligned in a 0 to 180 degree direction. And this is how it is seen, and it works beautifully. This is an 18-year-old patient with very high refraction, progressive loss of vision of 4 to 5 years, and this is Alport syndrome. Initially, we keep the cornea dry for the marking, and once that is done, then you can see this lenticonus here. This is in high magnification. As far as the cataract is concerned, it's a very soft cataract. So the patient is 18-year-old. And we do the marking and put a lens inside the bag. And since it's a young patient, it is against the astigmatism, with the astigmatism. So we rotate the lens and align it. And this is how it's going to see at the end. Now this patient came with a dense posterior cataract. So we started with a phaco, and then we realized that there is a hole. So we shifted to bimanual. So this is the hole which you can see into the PC, but it is not extending. So we are putting viscoelastic and implanting the lens. So you can put multifocal lens inside the bag, remove viscoelastic, do proper vitrectomy. This is anterior vitrectomy, and this is how it is going to be seen at the end. Now, if patient has been operated for LASIK, you can use Barrett-Trouquet. We have used Sharma's equation. The most important part of this is rhexis. The rhexis must cover at least 1.1 to 1.5 millimeter of your eye. So there will be no additional aberrations. Whenever you are going inside, you dip your instrument down and then enter. So the flap at the periphery will not get disturbed. Rest of the surgery is like any multifocal, softer cataract relatively, and the results are very gratifying. So upcoming new technologies for presbyopia correction are fluid vision, which is accommodative lens. It has got an annular haptics with the fluid. So whenever the accommodation is there, the lens swells and you get a 5 diopter of accommodation. Juveni is a similar principle, but it is modular. That means if any part is to be changed, it can be changed after years for correction of residual refractive error, gives accommodation of +3. This is synchronous dual optic accommodating eye, two components. Front moves forward and backward with the accommodation. This is lumina accommodating eye. It has got two parts attached at the haptics. This is placed in sulcus. Accommodation is +5. New lens works on a reverse accommodative principle. It has got two components. This is placed in a sulcus and works on the basis of the ciliary body movement. Accommodative amplitude is very good, 4 to 7. This is tetraflex IL, which induces higher order abrasion, 34% more than a monofocal IL, which mimics the natural accommodative abrasions. Tolerance is very good and with very accuracy of 1/8 of diopter compared to what we are presently using is having 1 diopter. So in conclusion, the results are very good. Patients are very happy if they understand the drawback. Choice depends upon the type of work and your profession. After surgery, the patient is getting glare and halos. To reduce that, you can use polarized glasses in sunlight, aromatic or yellow color goggles at night. Contrast can be improved with the additional light, and this surgery adds dimension to your practice and patients will be more happy. Thanks a lot for your patience here.
And that was excellent presentation, sir. It just shows the volume of work you have done. So because we are short of time, we'll just move quickly to the third presentation. Our third presentation is how to improve outcomes in pediatric cataract surgery by Dr. Parikshit Gokte. I know him from my post-graduation. He's an excellent surgeon. He is right now in a private practice since last 10 years. He has worked in H.V. Desai Eye Hospital, very famous hospital in Pune. And presently, he's an editor, sub-editor of Indian Journal of Ophthalmology. He's a secretary of International Society of Small Incision Cataract Surgeries. He has 90 papers in peer-reviewed journals, and I can go on talking. The whole session will not be enough regarding him. So without wasting time, I welcome Dr. Parikshit. Thank you so much for your busy schedule. I mean, time for in busy schedule.
Thank you, Dr. Devdatta, for the kind introduction. I'll be speaking on how to improve the outcomes in pediatric cataract surgery. At the outset, I would like to acknowledge Professor Rashid Al Saidi, the president of the Oman Ophthalmology Society, and our chairpersons, Dr. Muhammad Ali Arbi, Dr. Ahmad Al Maskari, and Dr. Devdatta Deshmukh, a friend. Well, Oman has always been famous for its trade and for its practices to save water and has been an innovator in its own regards. So today we'll be talking, after seeing two excellent presentations on phacoemulsification, on pediatric cataract surgery and how to improve its outcomes. We know that today cataract extraction with anterior vitrectomy and primary posterior capsulotomy has to be done till the age of 12 to 24 months. Then we put in PCIOLs. The AV-PPC can be dropped after 6 to 9 years, but the IOL has to be placed in a bag and sutures are a must. We must understand that child's eyes grow and develop. So when a child is born, the axial length is just 17 millimeters as compared to 24 in an adult eye. The mean keratometric power is 51 diopters, which later reduces by about 7. And the refractive changes that we see are mainly due to increase in the axial length. The maximum growth is in the first 2 years of life. That is why people think twice before putting in an IOL in that age. And the lens and the total eye power decreases by 10 diopters in the first year itself, which is why in the first year, even the infant aphakia treatment study said, keep the eye aphakic and later we can put in a secondary implant. Now, there is a refractive shift post-surgery, and the reasons are, of course, a normal physiological growth, then the age at the time of surgery, the amount of visual deprivation, laterality, and genetics. Now, this myopic shift in the first year can be almost about 7 diopters, But after the age of 14 years, there is hardly any shift.
Dr. Parikshit,
So,
I'm
yeah,
sorry to disturb you.
yeah.
You have not shared the presentation.
Oh my God. Oh, I'm sorry. I thought you had taken it. May I do it again?
Yeah,
May
now
I?
it's
Yeah. Sure. Since we have seen through this how to improve the outcomes in pediatric cataract surgery, well, acknowledgements to the organizers and my friend Dr. Devdutt and Professor Rashid Al Saidi. We know what is the standard practice for the treatment of pediatric cataract, so we'll not go into this. But we know that children's eyes grow and develop. And children's eyes are not just small adult eyes. When we are operating on a child, we have to understand that it is something which is very, very different. And this change is maximum in the first year of life, where the lens and the total eye power decreases by 10 diopters. So, these are the causes of refractive shift post surgery. When we look at the myopic shift, the maximum shift is in the first year of life, where it is almost 6 to 7 diopters. But later, after the age of 14 years, there is hardly any shift, and the shift is less than 1 diopter. So, when we are choosing a power for a child, which IOL is to be put in, one with expected growth and myopic shift, a child is expected to have good vision in adulthood. This results in significant hypermetropia initially. Now, this can cause near vision to be severely affected, and also there can be a dense amblyopia. So, if we think that finally in an adult, this child has to be emetropic, we put in, instead of a 30 diopters that has come, we have put a power of about 21 or 22, then it is very, very difficult to deal with it. So when we are choosing emetropia post-operatively in less than 2 years of age, so if a power of plus 30 has come on the A scan, if we put closer to plus 30, what will happen? There is easier amblyopia management in early post-operative period. This is especially true for a child with poor compliance and follow-up. And we know that in the societies where we stay, a lot of pediatric cataract patients come from very, very far, and they may not visit us regularly, and the follow-up may not be good. Now, with myopic shift and ocular growth, we can later use piggyback IOLs as Dr. Ladi just showed now. So when we are thinking of a child, when we think whether we should do emetropia now versus emetropia in an adult, I think we should think more of emetropia now. It's like this: looking at this child, will we stitch a suit for this child that 20 years later, during the child's wedding, this is the suit that the child will wear? No, we'll not do that, because in 20 years, we don't know how this child is going to grow and develop. So we do not know the power that is going to come later. So it is best to focus for emetropia today. So Inayadi had suggested a rule of 7 as to how to put in the lens. So if the child is 1 year old, you put a lens that is of plus 6 diopters, this, and you go ahead as a residual power. There is the Dahan's formula, where there is undercorrection in children less than 2 years, or undercorrection of 10% in children 2 to 8 years. The Prost formula is also similar. Again, studies from the USA also have said, but then no study demonstrates the visual advantage of one versus the other. So basically, if the child is less than 1 year old, it is best not to put in a IOL. Again, when we are doing biometry in children, eggshell length and keratometry is difficult to measure. There is a need for general anesthesia, and many a times the anesthesia has to be given just before the surgery is done, and that is where the A scan is done. So it's less reproducible, less predictable, with lower accuracy compared to adults, because there is no fixation or centration when a child's A scan is being done as the child is anesthetized. So here, of course, we always use the applanation technique. We use a handheld autokeratometer, and balanced salt solution can be instilled to maintain a smooth corneal surface. Later, we can always think of doing a piggyback IOL as the previous speaker had shown. And in piggyback IOLs, the most important thing to remember is that no knowledge of the power of the primary implant is needed. You just put in the piggyback IOL depending purely on what is the patient's refraction just now. So again, when we think of doing important consideration before operating in a child, I'll just take you through a few special situations. This is a unilateral cataract in a 7-month-old infant. This cataract was detected at the age of 4 months. So how do we operate? Which IOL do we put in? So if it's a unilateral cataract and the child is more than 6 months old, yes, we can think of putting in an IOL, because if we make him aphakic, doing the amblyopia treatment later is very difficult. Again, what power? Well, we put in a power that is closest to emetropia today. Suppose we have a child like this who has a bilateral cataract. Again, do we do it in a single setting or do we do it in 2 settings? So many surgeons would prefer to do one eye and do the second eye 3 days later. But nowadays, many surgeons do one eye, dewash, completely rewash with another set of consumables, and in the same anesthesia, do the second eye. Again, there are cataracts like these. Do we operate them? Generally, if the child's vision is better than 612, then it's best not to operate the child, because we may give some more clearer vision, but then the child's accommodation is lost. In the Indian setting and even in Arabia, when you are not sure of follow-up, we do PPC and AV till the age of 10 years. An automated vitrector is a must. Now, what to do first, putting in the implant or doing the anterior vitrectomy? Well, any will do, but generally it is safer to first put in the implant and then do the anterior vitrectomy. Now, in the type of surgery, I have been a great proponent of manual small incision cataract surgery, but this is one place where phacoemulsification is definitely superior. Because we have automated aspiration, we can do capsular polishing. So that is the best technique to do. And suturing of main ports and side ports ideally should be done in the first decade of life. So if the child is less than 10 years of age, we must do that. Which anesthesia to use? Well, sevoflurane is better, but in many places for an older child, we can even do ketamine and a block with a laryngeal masks. And nowadays, since we have such excellent phacosurgeons, any child more than 14 or 15 years old can even be taken under topical phacoemulsification. So IOLs, how early to be put in? Ideally not before 6 to 8 months for unilateral and 2 to 3, months for bilateral. Foldable always better. Put in hydrophobic lenses. But from my side, I would say that multifocals are a no-no, because a child's refraction is going to change. We are never going to get one IOL power. So it's best not to put in a multifocal, because the child will lose their contrast sensitivity. Again, follow up in the first 2 years for every 3 months, but then every year till the child is 18 years old. So we had done a study in Miraj looking at compliance to follow up. And here we find that mother's occupation, mother's education and father's occupation were the most important parameters. And just by doing a good follow up, a child's vision improves by almost 2 lines. So follow up is very, very important. And this has come from studies in Nepal, Mexico. Again, when we look at what finally affects the vision, it is the age of the surgery. Younger children don't do that well. Eyes which have poor preoperative vision also have poorer postoperative vision. And again, eyes on whom phaco is done do much better than manual small incision surgery. Also, dense cataracts, congenital cataracts, cataracts with fibrinous uveitis usually have poor vision. I'll just take 2 minutes and finish. Secondary glaucoma is also more common in congenital cataracts, not in developmental cataracts. Posterior capsular opacification is actually more common in developmental cataracts, because in congenital cataracts, we do AV PPC. And it's not just for vision, it is also for stereopsis. And if the surgery is done well, almost 1/3 children have some amount of stereopsis in bilateral cataracts. But in unilateral cataracts, the stereopsis is much, much lesser. Also in children, traumatic cataracts have a better result, as we have seen from studies from Africa and India. The reason is that the visual system is quite well developed in traumatic cataract. So if the cornea and the retina are not affected, they generally get good vision. So the summary is visual acuity after surgery is better when preoperative vision is better, if it is a developmental rather than a congenital cataract. When we are using automated vitrectors in older children, when there is no post-op uveitis and there is a regular follow-up. And of course, pediatric cataract surgery is much more expensive than adult cataract surgery. So we have to understand that, even if it's been given at a very subsidized cost. And these are the results from all over the world, those from USA or Dr. Wilson's or UK. In all of them, you will see that hardly 50% of children get vision better than 618. In adults, we know 95 to 96% eyes get vision better than 618. So the results in pediatric cataract surgery are not as good as in adults. So here we do not worry about the cylinder, only the sphere. So multifocals are a no-no, torics are rarely needed. But spectacles are going to be needed, so it's best to counsel the patient. And surgery is just one important step in a series of steps needed to improve a child's vision. And progressive specs do very well in children. Once more, thank you for your kind invite. Thank you.
Thank you, Doctor.
Any questions, please?
We'll take the questions at the end, Dr. Parikshit. Thank you so much for your elaborative lecture. And I would like to tell Dr. Yarubi to introduce our next speaker.
All right. So now we'll move to Dr. Amal Warikat. Dr. Amal Affar CS,
Sure.
she is a cornea and refractive consultant at King Hussein Medical Center. She is a fellow of Lehigh Hospital, Boston. She is the pioneer in the management of complicated cataract surgery. And she is as well a pioneer of Yemeni fixation. Maybe I can say in the Middle East, she did more than 200 cases. And I have an honor to participate in this. Dr. Amal, please.
Hello, everyone. Thank you, Dr. Yarubi, for the great presentation. And I would like to thank Dr. Rashid Al-Saidi, the president of the Omani Ophthalmic Society, and the organizing committee for the kind invitation and for the great organization and the rich content. We had wonderful memories from the last year meeting, and we look forward to meet you again next year, inshallah.
Inshallah.
So let's start by sharing my screen. So today I'm gonna present my talk about the management of subluxated cataracts, and there is no financial interest in the subject that I'm presenting today. So the assessment of the subluxated cataract starts in the preoperative area, where we need to do a careful slit lamp examination to assess the degree of iridodonesis, phacodonesis, abnormality in the anterior chamber depth, if there is any asymmetry, angle asymmetry, the density of the cataract, and the presence of vitreous in the anterior chamber, the status of the endothelium, and the age of the patient. The intraoperative signs of a weak zonule start by the beginning of the procedure. We might see a fluctuation in the anterior chamber depth. we might have difficulty in puncturing the anterior capsule, and we might see those star-shaped striations that is a sign of weak zonules. The lens may move during the capsulorhexis, and we will have difficulty in the rotation of the lens during hydrodissection. So the challenges, as we said, in the capsulorhexis, the lens is eccentric, the capsule is lax, the zonules are dehisced, and the capsulorhexis is difficult to initiate. Always use a dispersive viscoelastic in this step and start away from the loose zonules. Be as central as possible and try to have a smaller than the usual capsulorhexis size so that we can use the capsule hooks afterwards. If we need to do vitrectomy, then if we have any vitreous in the anterior chamber, this had to be addressed before starting the phacoemulsification. Do the procedure under low settings and with a high cut rate and use the cut IA setting. We can use triamcinolone to stain the vitreous and always use a dispersive viscoelastic. Regarding the capsule hooks, the capsule hooks come into in different forms, and they keep the capsule in adequate position and make the phacoemulsification within the bag possible. It decreases the stress on the zonules, and they are safe to be used. They cannot trip the anterior capsule edge. So the insertion of the capsule hooks, this is a case of a subluxated Marfan lens. I inject viscoelastic, I do some viscodissection before the insertion of the capsule hooks so that I will not trap any cortical fibers that would be difficult to remove afterwards. So viscodissection will help a lot, and we place the capsule hooks in the area of the weak zonules, and that would make the surgery much possible and doable in within the bag without stressing the zonules. Regarding the phacoemulsification, direct chop technique is a technique to be done in the state of weak zonules. Low settings, as I mentioned, dispersive viscoelastic, and we should always work in the center using the capsule hooks, and also start in the normal area and avoid any leak from the wound, from the main wound, so that the anterior chamber volume would be stabilized. And whenever you leave the eye, use a viscoelastic. So what's next? If we have, it depends on the amount of zonular weakness. If you have 1 to 2 clock hours, which is less than 1 quadrant, then we can use a 3-piece lens that can be placed in the axis of the zonular loss. If we have 1 to 2 quadrants of weakness, then we can use the capsule tension ring in the simplest form that has 2 eyelets. If we have more than this, 2 to 3 quadrants, then we can use the modified capsule tension ring, the Sioni ring that comes with the hooks, so that we can suture the ring to the sclera. And we can use the capsule tension segment, the Ahmed segment. I'll show you pictures of this too. If we have more than this, then we should look for another options for the IOL implantation and fixation. So the capsule tension ring is, in the simplest form, is designed and made out of PMMA. It has 2 eyelets to ease the manipulation of the capsule tension ring within the bag, and they come in different sizes according to the size of the eye. There are 2 FDA-approved forms, the Mortual ring and the Optic ring, with different sizes. So we should fill the bag with viscoelastic, and then we can insert the capsule tension ring either through an injector or manually. And in this step, we need to avoid dragging of the capsule while inserting the CTR. And then the terminal eyelet, we can use the reverse Sinski hook to put the CTR in the appropriate position within the capsular bag. The modified CTR, the one that comes with the single or a double fixation hook, this is located at a plane that is 0.25 millimeter above the plane of the capsule tension ring. And this is designed to sit above the anterior capsule, and we can pass the suture and fix it to the sclera. The CT segment or the Ahmed segment is also made out of PMMA and provides 90 degrees of capsular support. It has a central eyelet that is used for suturing, and it can be used in the presence of anterior or posterior capsular tear, and it is easier to deal with the cortical fibers with the CT segment because it's less likely to entrap the cortical fibers. We can use it intraoperatively. This is an iris hook. We can put it in the eyelet and stabilize the bag during the phacoemulsification procedure. This is a procedure for the fixation of the CT segment or the modified CT ring. So we use the 25 gauge needle 2 millimeters behind the limbus, and through the opposite paracentesis, we enter using 9-O-proline or a Gore-Tex suture, and we engage the suture into the lumen of the 25 gauge needle through the eyelet of the CT segment, and then we externalize the double-armed suture, and we do the same thing with the other end of the suture. So we'll have the suture coming out, and then we can tie it and stabilize the capsule by being sutured to the sclera. So if we have no capsular support, more than 3 clock hours of zonular weakness, then we should look for other options such as iris fixated lenses, iris sutured IOLs, transscleral fixation such as scleral sutured IOLs. This is an aniridia IOL in a patient with aphakia and aniridia. Or we can do the Yamani intrascleral fixation or the glued IOL. So this is the iris sutured IOL. This is a quick video showing the procedure. So we prolapse the optic of the lens into the anterior chamber. We fill with viscoelastic, and then we insert the 10-O-proline long needle through the iris tissue underneath the haptic, and then we exit through the cornea. This is the Kuglen hook. We externalize the suture, and we do the Siepser slip knot technique outside the eye. We do the tying and outside the eye, and then after this, we pull the knot inside the eye. We do the same thing for the other side of the lens, the other haptic, and then we push the optic behind the iris. So this is one of the methods where we can implant a lens in the absence of adequate capsular support. This is the CZ70BD. This is a lens that is used in scleral fixated IOLs. This is a one-piece lens, hard, and we use those eyelets and we use the 10-O-proline to fixate this lens to the sclera. This is a quick video too. I do this procedure by creating Hoffman pockets. This is a 3 by 3 millimeter scleral pocket without conjunctival dissection. And we do a scleral tunnel for the insertion of the lens. This is a big lens, so I prefer to do scleral tunnel for those lenses. Then I do the cow hedge technique, or the fixation of the suture at the eyelets outside the eye. We have 2 double-armed 10-O-proline, one on each side of the lens, through the main wound, and then I exit through the roof of the Hoffman pocket, the scleral tunnel. And then I introduce the lens into the eye, and we do the same thing for the trailing haptic. Now, after we are done with this, we cut the 2 needles, and then using a Kuglen hook, we introduce the sutures through the underneath the roof of the scleral tunnel. We do the tying so that the knot will slide within the tunnel. My favorite technique in the absence of capsular support is Yamani technique. So the Yamani technique starts by placing an anterior chamber. We insert the 3-piece lens into the eye with the leading haptic sitting on the iris, and the trailing haptic is outside the eye. I use a 30 gauge thin-walled needle. I mark the needle at 2 millimeters from the tip to guide me when to change my orientation and go inside the eye. Now, through the opposite paracentesis, I use a 23 gauge forceps to introduce or dock the haptic into the lumen of the 30 gauge needle. I cauterize it, but I don't push it completely until the final process. We do the same thing for the trailing haptic, and I use the tip of the needle to push the optic to put it in a more appropriate position for the docking technique. This step is a little bit challenging, but with practice, it becomes very easy. At the end, we also cauterize the trailing haptic and push the optic behind the iris tissue, and check the position of the lens, make sure that there is no tilt, and then push the flanges within the sclera. So take home message, always have plan A, plan B, and plan C before starting a surgery on subluxated cataracts. And thank you so much for your attention.
Yeah, that was a great presentation, Dr. Ahmad. Thank you so much. Because of short of time, we'll quickly move to the next presentation. Our next speaker is a young, dynamic, a very smart fellow. I know him from UG days in my postgraduate institute. He is none other than Dr. Vardhaman Kankriya. He is the director of Asian Eye Hospital in again Western city of Pune. He is the first fellow to go double this one international fellowship in a cornea. He has trained under very famous Dr. Palikaris, and he's the first surgeon even of his age to do 30,000 refractive procedures, and he has delivered over 100 national and international lectures. He's won best papers awards at various presentation meetings. He's a sub-editor, he's a section editor for refractive surgery in Indian Journal of Ophthalmology, and he's a scientific reviewer of 6 international journals. He has contributed to seven textbooks in refractive surgery, and he is the first Indian also to perform an FlexiView corneal inlays. So welcome, Dr. Vardhaman, and over to you.
Thank you. Thank you so much. So I think at the onset, I would like to thank Dr. Devdutt Deshmukh for such a kind introduction and for kind invitation. I've been knowing him since my undergraduate days when I was passionate about ophthalmology, and even from those times, we have known each other and have seen each other grow. So thank you again, Dr. Devdutt, and I'm going to start my presentation now. Yeah. So friends, in about 2015, we had published a paper in Ophthalmology Journal in which we looked at the satisfaction index after any cataract surgery. And the number one reason for dissatisfaction was remnant refractive error. So mind you that those were actually the virgin eyes. This study was done in Bascom Palmyra Institute with my mentor, Professor Sonia Yu. And now what we are going to talk about is a dynamic biometry after previous refractive surgery, which actually puts us through a lot of such surprises. So this presentation is going to be a short overview of background of this issue, why the biometry is erroneous after corneal refractive surgery, what is the way forward to get the accurate biometry in these patients, especially in patients who have undergone RK, ICL, and intacs as well. Friends, we all know that refractive surgery has come a long way. I think from the era of RK to today's era of SMILE, we have truly come a long way because of genius innovations of all these innovators. But the first time when the refractive surgery became truly globally popular was after LASIK surgery. So the first LASIK was done by my mentor, Professor Ioannis Palikaris, and this was done in 1990s. And this completely revolutionized laser refractive surgery world over, and suddenly people around the world started to have LASIK procedures on themselves to get rid of glasses. So these were the people in 1990s, which were called as baby boomer generation, which are presenting today for their cataract surgery. So if we look at these patients who are post LASIK, RK or PRK, they have relative intolerance for diminished vision, as we know, because they typically request for early cataract surgery. They always want a great vision with their understanding and the vision that they have enjoyed post LASIK. They also demand a great refractive outcome after their cataract surgery, as they have already achieved with LASIK procedure. And this is quite ironical because these are the very people and very patients who are actually desiring the most accurate postoperative refractive errors. And in them itself, the IOL calculations are going to be least predictable. Why is that? Basically because measurement of corneal power is difficult and erroneous in patients who have undergone corneal laser procedures or corneal refractive surgery, and often lead to hyperopic surprises. So before we understand why is that issue, I would like to actually take you through what formulas are used for virgin eyes and how do they work. So when we look at the virgin eyes, actually we have three kinds of formulae. First is the regression formula. They work on the meta-analytical data of all the previous calculations. So if we look at SRK, it works on A constant, keratometry of the patient, and axial length. If we go to SRK2, it is the same formula, but the A constant is actually optimized because A constant is known to be bigger for shorter eyes, which is hyperopic people, and it is going to be smaller for people who have myopic or longer eyes. But the more common formulas that we use currently are theoretical formulas or they are combined formulas. So in theoretical formulas, they typically work on the mathematical model of the eye. So if you look at the mathematical model of the eye, there is one principle it revolves around, and this principle is called as effective lens position. Effective lens position is the distance from the anterior refractive apex of the cornea till the principal axis of the intraocular lens, which is implanted. This effective lens position was seen to be actually fixed at 4 millimeters before, but now we do understand that effective lens position is going to be much more shorter in hyperopic eyes because they are shorter eyes, and it is going to be much more longer in myopic eyes because they are much more longer eyes. With this effective lens position prediction, there are a variety of formulas that we use today to come to the most accurate formulas and calculations. And they all revolve around mainly the keratometric data that we have to analyze, except for Haig's L. And this is something which is very, very crucial for us. So how and why is IOL power calculation is different and it is difficult after examer laser-based procedures such as PRK and LASIK surgery? So after PRK or LASIK, there are three sources of errors which develop. Number one is that there is a keratometric reading error, which is also called as index of refraction error. Number two is that the data from topography in keratometry is not reliable at all, which is called as the measurement error. And the third error is in the formula itself because there is an error in ELP prediction, as we have just seen. So what happens in keratometric reading error? In keratometric reading, as we all know, the dioptric power of the cornea is derived from a formula here. And this formula basically, it depends on the ratio of the anterior upon the posterior radius of curvature of cornea, which is known to be fixed at 1.21. But what happens if an eye has undergone corneal laser procedure? If the eye has undergone myopic corneal laser procedure, the anterior surface becomes flattened. If that is the case, then the keratometry, which is actually seen, is overestimated. Because we are overestimating the keratometry, we are going to underestimate the IOL power at the end, and that leads to hyperopic surprises. As against that, in hyperopic ablations, we know that the anterior refractive surface becomes more curved. So in this case, the effective keratometric reading is erroneous and it is underestimated. Because it is underestimated, therefore, the IOL power calculations are overestimated and we lead to myopic surprises. Second thing is the topographic or keratometry instrument, which itself is erroneous because we all know that this instruments, they calculate the keratometry at 3.2 millimeter zone and not at the center of the cornea, which is the most important keratometry for our IOL calculations. So that is the second error. And the third error, which is probably the most important error for us to know, is the ELP prediction error or the formula error. We have seen that in virgin eyes, the ELP prediction is the most important thing when it comes to biometric formulas, all these generation 3, 4, and 5 formulas. And the integral part of that is the keratometric acquisition. We have just seen that the keratometric acquisition in these people is erroneous. And that is the very reason that the formulas, they become erroneous themselves. So after myopic treatment, as we have seen, the keratometry is overestimated. Therefore, the effective lens position is underestimated. After hyperopic treatment, because the keratometry is underestimated, the effective lens position is going to be overestimated. And all these things together give rise to three errors, which together give rise to IOL power surprises in these patients. So with this background in place, now the question is that how do we calculate the IOL power in such patients? So we have already seen that in virgin eyes, the formulas that we use for ELP prediction, they largely depend on keratometry, which is erroneous after corneal laser procedure. However, there is one formula which is independent of the keratometry reading, and that formula is called as Haig's L formula. So this Haig's L formula, because it is K independent formula, can be used directly to calculate your IOL power after corneal laser procedures, and it is readily available with optical biometers such as IOL Master. If you do not have IOL Master, then you have to go with what is called as the K dependent formula. So when you have the keratometry reading with you, which is erroneous, as we have seen in this case, we have to actually use what is called as a Aremberry double K method to overcome this error. What is a Aremberry double K method? In Aremberry double K method, we use two keratometries. So first, we use a pre-operative, that is a pre-corneal laser procedure keratometry reading. This is determined and this is used for ELP prediction in the formulas. And the true post-operative keratometric reading is used post-corneal lasers, and this is to be used in the formula to be used for calculation of IOL power themselves. So how do we calculate a perioperative keratometry? It is very easy if you already have the history with you, and if you do not have it, if you have the topography of the post-operative keratometry of the corneal laser, and if you already know from patient that, okay, 5 diopters was treated for a patient who now has 41 diopter of keratometry, then we know the pre-operative keratometry was 46 diopters. The posterior radius of curvature does not change after your corneal laser. So this ratio of anterior to posterior can also be used, which is the ratio of 1.21 to calculate the pre-operative keratometric reading. For the post-operative true keratometric reading, either you go by the clinical known method, which is the history method, as we have just discussed. And if you do not have the history method with you, then the easiest way is actually to go to the pentacam. In the pentacam or tomography method, you have what is called as a pentacam holiday report. So at the EKR reading at 3 millimeters, if this is the reading that you will take for your keratometry, will be a true post-operative reading for this patient. If you have Galilei, you can use a Galilei total corneal power as well, but you have to modify all these factors with the modifying numbers which I have just noted there. There are other formulas which are also called as K-corrected methods, which work on Sharma's formula, theoretical formula, and Koch and Wang's formula. I'm not going into details of them because of the lack of time that we have. There is another question that all of the many people ask us, is that basically how to determine for such an eye whether we can implant a extended depth of focus lens or a multifocal lens. It is actually easy to understand, because if you go to the EKR of the pentacam, you will see this EKR graph has to have a single spike. And if it has a single spike, means that the keratometry is actually evenly distributed. And that means in such people, a extended depth of focus lens, such as a symphony lens, can be actually used as well. So with this background in place, what are the best formula for post corneal laser eyes? Because the virgin formula wouldn't work. So as you can see, this is the long list of formulas which have been seen by a variety of publications now to be very, very accurate. But if we actually compare all of them and put them together, you can easily have the facility to come to all these formulas together in what is called as the ASCRS calculator. So if you just go on the ASCRS website and put in all the data on this website, you will actually get all this formula and their results in front of you so that you can plan very well. There are other websites as well. I'm not going into the details of the other websites. But when we are going to the ASCRS online calculation, you can see that you have to feed which refractive surgery was put in, all the known perioperative and the current data that you already have. And by variety of formulas, you will actually get the IOL power to be calculated, and you can also take the average of this calculation and go slightly towards myopic side. This is a very good publication by Wang et al. They have actually compared all formulas by ASCRS, and they have seen that the OCT-based keratometry and the true K no history method was probably the most accurate in the ASCRS calculation method. Not only the biometry, but you have to also choose the right IOL. In hyperopic LASIK, it is better that you use a non-aspheric IOL because hyperopic LASIK induces negative spherical aberrations. After a patient has undergone myopic LASIK surgery, the patient has been induced with positive spherical aberration. So you should use a lens with maximum negative aspheric value, which is basically AMO thickness. In patients who have complex aberrations such as post-RK, try to use a lens which has zero spherical aberrations. And with patients of significant astigmatism, of course, you can use a toric IOL. So I'm just going to wrap up in the next 2 or 3 slides in the next 1 minute. So this is one study which we had published from Bascom Palmer in back in 2013, where we actually calculated all these formulas from ASCRS and we compared it with intraoperative wavefront aberrometry. The point I want to draw here is that all other formulas, they work very well in post-LASIK eyes, fairly well. But when it comes to post-RK eyes, the plus minus 0.5 prediction was possible in only 14% of the eyes. So that tells that after RK, it can become highly erroneous. So this is one such patient that you can see that we have done. And this is variety of formulas that you can get in ASCRS as well as on the IOL master. But there was a wide variety and of this reading. So it becomes very confusing. So what we do in this cases is that we go for what is called as the intraoperative retinoscopy method. With the intraoperative retinoscopy method in this patient, we got a retinoscopy of 11.50, and you have to just calculate and multiply it by 1.7, and the figure which came was 19.55, and we selected 20 diopters for this patient. And as you can see in the left eye, from -10, the patient actually reduced to almost plano outcomes. We have seen that with this retinoscopy method, 100% of our eyes has been within plus minus 1 diopter, where in the literature it is just 25% of the eyes by other methods. After ICL procedure, the biometry essentially remains the same because the ICL is only a transparent optical lens which is there. It does not change your IOL power calculations. However, if somebody has undergone intacs for keratoconus, then you have to go back again to the ASCRS formula. So friends, we have to understand these patients are unique, the requirements are unique, and we have to take the right measures to make sure that we give them the best possible post-operative outcomes when it comes to biometry. I would like to thank again Dr. Devdatta for his very kind introduction and kind invitation for MIOC and all the organizing committee. Thank you very much. Thank you.
Yeah, thank you, Dr. Vardhaman. It was a great presentation, very much basics, which we need to look on. And then it's very common now to have such a scenario of post-refractive surgery, undergoing cataract surgeries. Thank you so much.
Thank you. Thank you so much.
Yeah, we'll move to our next presenter, Dr. My colleague, Dr. Mohammad Yarubi. He will talk on scleral fixated lens. He's a very versatile surgeon. I would say he can do anything from ECC, from scleral fixated lenses to refractive surgeries. And recently he has completed a cornea and cornea fellowship from Jordan. So over to you, Dr. Yarubi.
Thank you very much, Dr. Tish, for the introduction. Is it clear? Is it clear?
Yes, sir. Yes, doctor.
Okay. So I'm going to talk about scleral fixation of IOL overview. This is my outline. So what are the predisposing factors for posterior capsule rupture that need later on scleral fixated IOL? Usually, these patient-related factors, such as a very uncooperative patient who is dementic, for example, extraocular factors like poor visibility, like a severe corneal opacity. Also, intraocular factors like severe pseudo-exfoliation and surgeon-related factors like he is inexperienced. Intra-op factors like small rexes or problems intra-op regarding the rexes radial tear. Unfamiliarity with the machine also is an important factor. According to US statistics, causes of BC rupture, open globe injury come to the first, followed by Marfan, and later on by third cause by pseudo-exfoliation. Actually, pseudo-exfoliation account for more than 50% of late IOL dislocation. Of course, we should not forget the intra-op PC rupture, which account up to 4% in the US statistics. So ideally, we should implant intraocular in the intracapsular. If there is deficient posterior capsule due to rupture, then we can still rescue it in the sulcus. However, in complete deficient bag, then we need to think about something else like anterior chamber IOL or iris fixated IOL or scleral fixated IOL through suture or through haptic fixation or glue assistance. So what different scenario we encounter pre-op? If the patient IOL is subluxated or dislocated, but still can be repositioned. If cannot be repositioned, then it can be exchanged. However, if the patient is aphakic, then we need to put secondary IOL. In case of one piece IOL which is dislocated in the vitreous, then still can be rescued to be put in the bag. But in a better option, if it was 3 piece, we are lucky that still can rescue in the sulcus, or it can be sutured in the sclera or haptic fixation like Yamani. And that's why we usually encourage in those who anticipate a complicated surgery that to put 3 piece initially, so that later we can manage easily. So sclera fixated IOL can be done by anterior posterior segment. They have both a better visual outcome. However, through anterior vitrectomy, they are more likely to experience less dislocation. However, and through posterior pars plana, they can experience more myopic shift with a high rate of IOL capture. Actually, the advantage of posterior approach that the surgeon may be able to deal with the unexpected intra-op complication, such as posterior IOL dislocation, or he can manage to repair intra-op retinal tears or detachment. So timing of scleral fixated IOL, it can be done as intra-op or later on a secondary procedure. However, both of these approaches have a similar visual outcomes and similar complication rate. So that depends actually on the surgeon comfort level and experience, and also on the clinical circumstances related to this intra-op complication. As mentioned earlier, special cases in aphakic children, actually putting SAIOL or iris fixated IOL has a high complication rate because it can cause chronic iris chafing, glaucoma, or persistent inflammation. So most of the surgeons prefer actually to put the patient aphakic or using contact lens. A promising result with using sutureless intrascleral haptic fixation like Yamani. So as we said, a suture or versus sutureless scleral fixation, both of these approaches have a similar expected visual acuity. However, the suture IOL compared to the sutureless have a higher rate of both of glaucoma and inflammation. It looks that the surgery time is shorter using a sutureless technique. So a sutureless intrascleral fixation is effective and associated with a superior outcome compared to the suture group. Actually, when we decide to use a suture, we can use one of these, 10O Prolene or 9O Prolene, or more higher tensile strength like 7O Gore-Tex. In the suture, we can either do the fibrin glue or the haptic fixation, and it has a specific lens to use through haptic fixation. In general, complication of scleral fixated IOL can cause corneal edema, retinal detachment, intraocular hemorrhage like vitreous hemorrhage, suture-related erosions, infections, And IOL dislocation or tilt or can also be caused by broken haptics. A high OIB also can be encountered. So why now we can switch to Yamani interscleral haptic fixation? Because it is a symbol and no need for conjunctival dissection or using a flap, a scleral flap. It can be implemented through a small incision, and it's the fastest method of sutureless BCIOL. Also, the eye tend to be very quiet post-operatively. However, there are some limitations. It's still surgically challenging to most of the worldwide surgeons, and it requires familiarity with the anterior vitrectomy technique. Haptic placement should be aligned 180 degree. And the difficulty comes actually from obstructing the surgeon view. And it requires also a specific IOL like ZA903, 9003 or MA60 or a CT Lucia. And it is not suitable in disorganized anterior segment. So this is again a scheme for aphakia management, either through intact anterior capsule using circus 3-piece IOL, or in a deficient posterior capsule where still can fixate through the iris, or IOL, ACIOL, or a suture technique by glued or iris screw or through Yaman. Thank you. This comes to end my presentation. Thanks.
Yeah, that was an excellent presentation, Dr. Yarubi.
Thanks.
We are very happy to have you here, and we are quite relieved you will take care of our phakic patients in the future.
Thank you very much. Thank you. Now we'll move to Dr. Deshmukh. Dr. Deshmukh is a senior specialist. He is a fellow of ICO and FRCB, FRCS Glasgow. He has a gold medalist from in DOMS and gold medal by Pone. Since 2006, he is working as anterior segment senior specialist as well as a medical retina specialist in AFH. Dr. Deshmukh, please.
Thank you so much, Dr. Yarubi, for the introduction. I'll just quickly go through my today's topic, that is management of astigmatism in a modern day cataract surgery. A lot has happened in last 10 years in this field. As you know, advances in the intraocular designs and surgical techniques have increased patients' expectations, and it is very important to address the astigmatism in order to achieve an optimal post-operative outcome, because a chunk of our patients do have an astigmatism to some extent. Residual astigmatism of 0.75 or more can cause halos and ghosting of images, and even the multifocal IOLs with diffractive optics are less forgiving. So conventionally, it is targeted. It is recommended that our target should be around 0.25 to 0.5 with the rule astigmatism in any cataract surgery. So how to measure the corneal astigmatism? There is a landmark paper by Douglas Koch in 2013, which changed our approach totally. It shows the importance of posterior corneal astigmatism, which has to be considered in any kind of calculations. And it estimates that the average value of this posterior astigmatism is 0.3 diopter. And the total astigmatism is overestimated by 0.5 in a with the rule astigmatism and underestimated in the against the rule astigmatism. So initially, there were various nomograms were recommended, like Goggin and by Koch himself. But the later on, the Barrett-Storick calculator with the universal 2 formula has eased out our lives, and it calculates the posterior astigmatism based on theoretical model. Even the latest machines like IOL Master 700, even Oculus Pentacam and Galilei G6, it directly estimates the posterior corneal astigmatism. So what are the treatment options we have? We have clear corneal incisions on the steepest axis. Then we have paired opposite clear corneal incisions. We have limbal relaxing incisions. Then the latest ones are femtosecond laser assisted keratotomy and toric IOL. And of course, last is bioptics, that is post cataract excimer laser refractive surgeries. So clear corneal incision on the steepest axis is the most useful and technique to go for a low astigmatism. As our incision sizes have decreased to 2.4, the mean SIA they say is around 0.35 diopters. But recent work by Dr. Warren Hill, Dr. Koch, Dr. Holade has shown that instead of a mean or a median SIA, we should go for a centroid value that is based on a vector analysis. And that value comes to only 0.12 diopter. And this is incorporated in most of our modern machines nowadays. Paired opposite clear corneal incisions can be done, but it lacks the predictability, as well as, of course, there is an increased risk of endophthalmitis. So it is not routinely done. Coming to limbal relaxing incisions, this was started way back in 1995 by Ligabe, and it was based on nomograms, which were popularly known as Dono and Napa, done by Nikamin and Donenfeld. This is a manual technique which is done with an metallic or a diamond keratotomy blade. And what you do is go on an LRI calculator, and this will go on. This will give us an diagrammatic presentation to how to go about it. And these were the nomograms which were used initially. Then entry of femtosecond laser has revolutionized this approach because of its precision, and we can go for two kinds of incisions. That is, one is penetrating, and the other will even we can go for an intrastomal cuts. And the best part is that we can titrate the magnitude post-operatively. If the result is not favorable, we can open the incisions on the surface with the help of Sinski's hook. So even now, the nomograms which were originally done by Dono and Napa, they were modified because these incisions are slightly central, and they have to be modified according to the value of posterior corneal astigmatism or type of astigmatism, I would say. So various papers recently has shown a very effective technique. This is a very effective technique. Paper by John Chang has shown that both the techniques, intrastomal as well as penetrating, have comparable results, and it's a good choice to correct the low amount of astigmatism up to 1.5 diopters. Even the paper by Alexander Day and Julian Stevens showed the similar results, and their correction was around 63%. They have invented their own website, that is femtoemulsification.com, suitable for a catalyst machine, femto laser platform for the calculations. What was our experience? We did around 15 cases till now. We have gone for, we have done with Lensex. We went for a simultaneous flags with AK. The Callisto guidance was used in some cases. We went for an 8mm arc. We modified Donenfeld nomogram as we went for 100% for against the rule, 80% for with the rule, and 90% for an oblique astigmatism. Depth was kept at 80%. The mean preoperative astigmatism was 1.56, and we succeeded in reducing that to a figure of 0.65 diopter. However, the intrastomal AK did not show significant correction even at 2 months follow-up, but no major complications were encountered. So this is a short video which shows the actual procedure. The docking is being done. Initially, the capsulotomy is done. This is followed by a lenticular crack. Followed by astigmatic keratotomy, 2 of them in this case. And the lastly, the main incision is getting done. So I'll just touch upon this toric IOL implantation. As you know, this is a method of choice for correcting high levels of astigmatism as a most predictable method. But you have to remember one thing, toric IOLs can rotate after implantation, and the loss of astigmatic correction is 3.5% per degree of rotation. How to mark the axis? We can go for earlier methods like freehand marking. Then we have a slit lamp method, and there are different markers available like bubble markers. But nowadays, because of the high-tech machines, we can have a markerless toric IOL alignment with the help of image-guided surgery tools, namely Callisto, Varion, True Vision, or we can even go for an intraoperative aberrometry like Aura or Holos. The recent one is that is known as IntelliAxis by Lenser machine. What they do, they put on two tabs are created on the anterior capsule for the IOL alignment, and it also reduces the parallax that sometimes happens between the cornea and lens. So I have proposed this step ladder approach for our center. If the astigmatism is less than 1 diopter, usually we go for an steep axis incision or a single arc femtosecond laser astigmatic keratotomy. If it is between 1 to 1.75, usually we go for a double arc FSAK. And if it is more than 1.75, usually we go for a toric IOL implantation. So to summarize, for 5 key factors in astigmatic planning success. Firstly, we have to always consider posterior corneal astigmatism. Take a value of centroid SI as 0.1. Always remember of that there is a long-term drift which happens with against the rule, that is 0.34 diopter per decade, and even you can flip the axis if the previous the basic astigmatism is against the rule. Thank you so much.
Thank you so much, Dr. Deshmukh. Now for the last session, it's about flex versus manual phaco by Dr. Millen. Dr. Millen, he's MBBS and MS from Government Medical College, Miraj. He is a fellow of RCS, and he's a plastic fellow from Regional Institute, Chennai. He worked in various government and private medical college as a professor. He is working as an anterior segment surgeon and oculoplastic surgery at AFH since 2013. Dr. Millen, please. Dr. Millen, can you hear me? Can you start your video, please? Yes. Share your screen, please. Okay, thank you, Doctor.
Good evening, and at the outset, I would like to thank the organizers of the conference for giving me this opportunity. I'm going to talk about femtosecond laser-assisted cataract surgery versus routine phacoemulsification. And I don't have any financial disclosures. My talk will be divided into 3 parts. In the beginning, I will talk about femtosecond laser. In second part, I will talk my experience about femtosecond laser versus phaco. And in last part, we will talk about advantages and disadvantages of this technique. The femtosecond laser, when it is absorbed by the tissue, forms a plasma of free electrons and ionized molecules. The plasma expands and forms an acoustic shock wave. With time, the plasma cools and forms cavitation bubbles. And these bubbles separate the tissue without heat generation and destruction to the nearby tissue. Femtosecond is a solid neodymium doped glass laser with a wavelength of 1053 nanometers, and it has a precise focusing of 0.3 microns. It's accurate within 5 microns in the anterior chamber, and this accuracy is responsible for the precision. The first step is docking of the patient's interface, and depending on the manufacturer, it could be contact or non-contact design. We are using Lensex machine by the Alcon, and it has a contact design. The video microscopy monitors the descent as the laser delivery system is lowered. The next step is corneal applanation, and once the cornea is applanated, the suction is applied. We'll see a fractured bubble here when the cornea is applanated, and once the cornea is applanated, the suction is applied and the docking is complete. During the docking, the intraocular pressure may rise 15 to 20 millimeters of mercury. Sometimes there are conjunctival hemorrhages. Perfect docking has learning curve, and even the experienced phacosurgeon who is novice to the femtosecond platform can have difficulty, especially the long nose, deep-seated eye, kyphosis, scoliosis may cause difficulty. The next step is imaging. Either the OCT, that is spectral domain optical coherence tomography, or ray tracing reconstruction is used to get images, and the images seen on the monitor are used to map the treatment plan. Now, the next step is limbal centration and primary and secondary incision boundary adjustment. You can see here in this video, the limbal ring is centered, and after that, the main wound is adjusted. The next will be next will be capsulotomy and nucleotomy ring adjustment with the pupil. You can see here there are two rings. The nucleotomy ring is slightly larger than the capsulotomy ring. Next will be the adjustment of arcuate incisions. The arcuate incisions are taken at the 8.5 to 9 millimeters of arc and along the steep axis of the astigmatism. Here we have planned two arcuate incisions. I have not planned the secondary incisions because the arcuate incisions were large. Next, the OCT scan is initiated and the wave pattern of capsulotomy is adjusted. The, the peak as well as tuft is adjusted as it is seen here. Next step would be adjustment of lens offset and lens fragmentation zone. From the posterior capsule about 800 micron and from the pupillary margin about 250 micron offset is kept, and this will avoid the complication. Next will be the tunnel thickness and wound length adjustment. You can see here the tunnel length is adjusted. Once this treatment plan is finalized, you press the foot switch and the laser emission starts. The process is monitored on the screen through real-time OCT images, and the in sequence of anterior capsulotomy as you can see here. Next would be lens fragmentation. Followed by arcuate incisions, 2 arcuate incisions. And last would be primary incision. The fragmentation pattern is based on the density of the nucleus. There could be 4 patterns. The cross pattern, in cross pattern you get 4 segments. In pi pattern there are 6 segments. In hybrid pattern, the central liquefaction zone with peripheral cuts, and in grid pattern the laser makes multiple small pieces. In cross pattern and pi pattern, the laser energy is more when we emulsify the nucleus, whereas in hybrid and grid pattern, the energy required during the emulsification is less. We did pilot study, small study of 40 cases. 20 cases were operated by routine phaco and 20 cases were operated by flax. And I was the single surgeon. Halcon Centurion phaco machine was used. And in selection criteria, we selected clean cut cases for flax, whereas the patients with ocular comorbidity were operated by routine phaco. In this graphs, you will see the total US time, CDE, that is average cumulative dissipated energy, total aspiration time, and total estimated fluid was less in flax compared to routine phaco. The average endothelial loss at the end of 6 months was 9.88% in routine phaco and 9.35% in flax. 100% patients in flax group attended 6-9 and better vision, whereas 70% attended this vision. About 30% had less vision, and the reason was the uncorrected astigmatism or the ocular comorbidity like trachomatis scarring, diabetic maculopathy, etc. The advantages of flax are it is accurate and predictable technique. The capsulotomy is precise in terms of centration, size, shape, minimal intra and intrasurgeon variation. In intumescent and subluxated cataract, it is helpful. It reduces posterior capsular opacification. It has better lens effective position. It reduces higher order aberrations. Prior fragmentation reduces endothelial loss. The wound construction is good, so the wound complications are less. Challenging situations like narrow angle glaucoma, pseudoexfoliation, floppy iris syndrome, hard nucleus, such situation the flax is very helpful. The post-operative inflammation is minimal. The arcuate incisions help to correct the astigmatism. Some machines have a device that will help in toric lens implantation, and for beginner, because the initial steps are performed by machine, it is helpful to teach the phaco to the beginner. Disadvantage, however, it is expensive procedure, it is time consuming, is not useful when the cornea is scarred or pupil is constricted. Sometimes the incision and capsulotomy is incomplete. The laser delivery near the pupil causes constriction of pupil, and subsequent phaco emulsification may be difficult, and it is not portable machine. In summary, the advent of flax has augmented the accuracy and predictability of the cataract surgery, making it refractive surgery. Both techniques of cataract surgery, that is flax and routine phaco, works equally good in expert's hand, and that was our experience. Thank you.
Yeah, that was excellent presentation, Dr. Milind. With this, we have come to an end to this cataract session. We are already short of time. I'll just check whether we have any questions. I'd like to thank all the guest speakers for their valuable time from their busy clinical schedule. So any comments from the speakers?
Well, thank you for at least virtually having us in Oman, Dr. Devdatta. I mean, that's how we can travel.
True.
And I mean, I have in my 2 visits there, it's a very lovely country with very warm people. And it's good to see you doing this meeting with so many international societies put together. So let's hope we meet and learn from you again.
Yeah, thank you so much. Thank you for your time. And I wish you all the best and Happy New Year in advance. And stay safe.
Thank you so much.